badass doctors! Today we have a 35-year-old man presenting to your clinic for a general checkup and a cholesterol screening. He denies having medical problems and takes no medications on a regular basis. He works as a computer programmer, exercises regularly at a gym, and does not smoke or use illicit drugs. He drinks 2 to 3 beers on the weekends. His father suffered his first heart attack at age 42 and eventually died of complications of heart disease at age 49. The patient's older brother recently was diagnosed with high cholesterol. His vitals consist of blood pressure of 125/74 and heart rate of 72. He is 69 inches tall and weighs 165 pounds. His physical examination is unremarkable. Fasting lipid levels are drawn. The next day, you receive the results. It came back as total cholesterol at 362, triglycerides at 200, HDL cholesterol at 36, and LDL at 266. As you're reading the case, I hope you're naturally coming up with a differential diagnosis, a DDX, for this patient even before glancing at the multiple choice answers on boards, because in real life, patients aren't multiple choice questions.
So, will it be Bachelorette number 1, Bachelorette number 2, or Bachelorette number 3? 3 number 3, my lord.
The first thing I want to know is, are these normal results? The way that I remember what normal lipid panel results are supposed to look like is by putting the results in this specific order. Total cholesterol, TC, then triglycerides, TG, since C comes before G, then LDL cholesterol, because these first 3 are numbers that we typically want lower results for, and HDL, which is the good cholesterol. So after rearranging the order, I remember the numbers 200, 150, 100, and 45. As you can see, we are decreasing these numbers by 50. So the first 3 numbers are the upper limits of the normal range for total cholesterol, triglycerides, and LDL cholesterol respectively. And the last number 45 is a lower limit of the normal range for HDL. I have highlighted in blue what I think were the breadcrumbs for this case to come up with a working diagnosis. So let's put on our Dr. Detective caps and follow these breadcrumbs. Alright, let's start off with the good news. We have a healthy young man with no medical complaints, an unremarkable physical exam with no signs or symptoms of vascular disease, and a calculated BMI of 24.4, which is in the normal category. He's also a non-smoker and exercises regularly. Seems like he's doing his part. However, what's going against him is a strong family history of cardiovascular disease. His dad had a premature myocardial infarction, and his brother has hypercholesterolemia. Incidentally, his lipid panel shows that he has dyslipidemia as well, but he doesn't have any apparent secondary causes of dyslipidemia. For our patient, due to the absence and signs and symptoms of dyslipidemia, it's very important to do a minimal workup of ruling out the other common causes of dyslipidemia, such as diabetes, hypothyroidism, obstructive liver disease, chronic renal failure, nephrotic syndrome, and medication side effects from progestins, anabolic steroids, and corticosteroids. And that's because steroid hormones are derived from cholesterol. Based on the evidence provided, what is your working diagnosis? If you said the heterozygous form of familial hypercholesterolemia, I'd be hard-pressed impressed. Here's a quick definition to remind you of familial hypercholesterolemia, also known as FH. It's basically a genetic disorder that causes soaring levels of plaque-building LDL cholesterol due to defective or absent LDL surface receptors, leading to its inability to metabolize LDL particles. So if it's left undiagnosed, then it can cause aggressive premature cardiovascular disease and stroke. Because this patient doesn't have tendon xanthomas, xanthelasma palpebrarum, argus senalis corneae, angina, or development of an aortic stenotic murmur, it appears he may have the heterozygous form of FH, instead of the more severe but less common form, which is the homozygous familial hypercholesterolemia. The probable diagnosis of heterozygous familial hypercholesterolemia can be made if the LDL cholesterol level is greater than 330 milligrams per deciliter, or if tendon xanthomas are present in a patient with an LDL cholesterol level above the 95th percentile. Definitive diagnosis can be made only with gene or receptor analysis. However, a substantial increase in serum triglyceride levels should raise the possibility of another lipid disorder. Here's a quick reminder of the coronary heart disease risk factors. They are cigarette smoking, hypertension, low HDL cholesterol, anywhere under 40 milligrams per deciliter, family history of premature coronary artery disease, especially in men under the age of 55 and in women under the age of 65, older age, so men over the age of 45 and women over the age of 55, and diabetes. The recommended interval for cholesterol screening in a healthy adult population is every 5 years, and that's because cholesterol levels do not change rapidly over a person's lifetime. In terms of nutrition, according to the 2019 guidelines for the American College of Cardiology and the American Heart Association, dietary patterns associated with cardiovascular disease mortality include sugar, low-calorie sweeteners, high-carb diets, low-carb diets, refined grains, trans fat, saturated fat, sodium, red meat, and processed red meat such as bacon, salami, ham, hot dogs, and sausages.
Eat meat. You're either in this category or this.
All adults should consume a healthy plant-based or Mediterranean-like diet, high in vegetables, fruits, nuts, whole grains, lean vegetables or animal protein, preferably fish, and vegetable fiber, which has been shown to lower the risk of all-cause mortality compared to control or standard diet. In terms of physical activity, according to the 2019 guidelines from the American College of Cardiology and the American Heart Association, they're recommending that all adults should engage in at least 150 minutes per week of moderate to intense exercise, or 75 minutes per week of vigorous to intense physical activity, including resistance exercise. In terms of chemoprevention, we would put our patient on a statin to lower his total and LDL cholesterol levels. And to figure out the intensity of the regime, we would use the atherosclerotic cardiovascular disease risk estimator according to his lipid panel results. Just to quickly review, these are the following groups of when we would use statin therapy according to the 2019 guidelines from the American College of Cardiology and the American Heart Association. 1. Patients with known atherosclerotic cardiovascular disease. So if they had a history of MI, angina, stroke, peripheral arterial disease, coronary or other revascularization procedures. 2. Diabetic patients ages 40 to 75. 3. Patients with LDL cholesterol greater than 190 milligrams per deciliter. And 4. Patients ages 40 through 75 without diagnosed cardiovascular disease or diabetes, but with a 10-year risk of cardiovascular events greater than or equal to 7.5%. Let's quickly review the drugs for hyperlipidemia. The first drug class is going to be our statins, also known as the HMG-CoA reductase inhibitors. They are known to lower LDL cholesterol by 25 to 60%, lower triglycerides by 10 to 25%, and raise HDL cholesterol by 5 to 10%. Major side effects that we should know for statin drugs are myalgias, so any of those muscle aches and tenderness, right? So we would be monitoring creatine kinase. And another side effect of them would be hepatotoxicity, so we would be looking for elevated liver enzymes by monitoring LFTs. From a naturopathic physician's point of view, I would recommend patients on a statin with CoQ10 because statins block HMG-CoA reductase, the enzyme that converts HMG-CoA to mevalonic acid, which naturally converts to CoQ10, which is a compound that our body naturally makes and stores in the mitochondria to help generate energy, aka ATP, and serve as an antioxidant to protect cells from oxidative damage. So CoQ10 would be beneficial in those with heart disease, brain disorders, diabetes, and cancer. Since our bodies decrease the natural production of CoQ10 as we age, I would recommend 900 to 200 milligrams of CoQ10 daily with a fat-containing meal in the morning. whereas the statin would be best taken at bedtime since cholesterol production is highest between midnight and 5 a.m. Be sure to tell your patients to avoid drinking or eating grapefruit and avoid increased alcohol intake. Discontinue the statin if the patient has myalgia because the patient could get rhabdomyolysis, which is the breakdown of muscle tissue that releases a damaging protein into the blood and damages kidneys. Statins are contraindicated in pregnancy and those with liver or kidney disease. The next class of drug is nicotinic acid, which is a form of niacin, the water-soluble vitamin B3. Niacin stimulates hepatic lipid metabolism, so its main goal is to raise HDL cholesterol by 15 to 30% and lower LDL cholesterol by 15 to 25% and triglycerides by 25 to 35%. Please don't confuse nicotinic acid with niacinamide or nicotinamide, which doesn't lower cholesterol. The main side effects of niacin are flushing and hepatotoxicity. To reduce hepatotoxicity, it is best taken with supplements B complex and vitamin C, which should be taken on a 1-to-1 ratio with niacin, which should be dosed at least 1,500 to 200 milligrams daily to have any significant effect on lipids. The next class of drugs are bile acid resins such as cholestyramine and cholesterol. They bind bile acids and sequester them from the enteropathic circulation. The liver then produces more bile acids to replace those that have been lost. Because the body uses cholesterol to make bile acids, this reduces LDL cholesterol by 20 to 30% and raises HDL cholesterol by 5%. The main side effects are constipation, nausea, and GI discomfort. Because they bind to other drugs and fat-soluble vitamins, be sure to advise your patient that bile acid sequestrants should be spaced several hours apart from other drugs and supplements. The next class of drugs are fibric acid derivatives like gemfibrozil and fenofibrate. They're mainly used to lower triglycerides by 25 to 40% and raise HDL cholesterol by 5 to 15%. They lower circulating triglycerides by reducing the liver's production of VLDL and by speeding up the removal of triglycerides from the blood. Main side effects are gallstones, nausea, and hepatotoxicity, so monitor LFTs. They are contraindicated in patients with gallbladder disease. The last class of drugs for hyperlipidemia are cholesterol absorption inhibitors like ezetimibe. They lower LDL cholesterol by 15%. The main side effects are diarrhea and GI upset, and be sure to monitor LFTs for patients on this drug as well. As a nod to my profession as a naturopathic physician, I'm going to talk about some botanical medicine that we use to lower lipid levels. So allium cepa, which is onion, is one. Allium sativum, which is garlic, is another. And the last one is Cinera scolimus, which is artichoke leaves. Based on science-based evidence ranging from human studies to animal studies, these are the foods that are known to decrease cholesterol levels. While we typically eat these herbs, vegetables, fruits, and grains, I do want to point out that patients should be talking to their doctors about any supplement use. Just because it's deemed natural doesn't mean it's always safe. For example, red yeast rice is a powerful supplement mainly used to lower cholesterol, but it contains monocolin K, which is the same active ingredient found in lovastatin, so it can be just as hepatotoxic like the statin drug.
Well, here's a bowl of steaming Quaker oatmeal, and I can't think of a healthier way to start the day. Quaker oats. It's the right thing to do.
All right, doctors, this is Dr. Sola signing off. See you next time.
Mwah!
Hey, please have a dream, my lord.